Welcome to the deep dive. Today, we're diving straight into something really fundamental, your cardiovascular system.
Right, the body's engine room, basically.
Exactly. You sent over a fantastic set of materials, and we're going to explore, how blood flows, what happens when things go wrong, especially blood clots, and we'll even take a close look at a specific medication called Exhibion.
Sounds good. The goal here, I think, is to really pull out the key insights from all that information you shared.
Yeah, to give everyone listening a clearer picture of how this incredibly vital system actually works and the potential challenges it faces.
It's also interconnected, isn't it? From the tiniest blood cell right up to the major conditions.
Okay, so where should we start? How about the heart itself, the main pump?
Makes sense. It's really the core of the whole system, and it's actually two pumps working together.
Two pumps. How so?
Well, you've got one side dealing with the oxygen-poor blood that's come back from the body, sending it off to the lungs.
Ah, right, to pick up fresh oxygen.
Exactly. And then the other side takes that newly oxygenated blood from the lungs and pumps it out to, well, everywhere else.
And that happens in those four chambers, the atria and ventricles.
Precisely. The atria, the top two, they sort of receive the incoming blood. Think of them as waiting rooms.
Okay.
And the ventricles, the bottom two, they're the powerhouses. They do the actual pumping out. Especially the left ventricle, it needs more muscle because it's pushing blood much further.
Right, all around the body compared to the right ventricle just going to the lungs.
Yeah, shorter trip.
And this whole process is a constant cycle, right? The filling phase, diastole, and the pumping phase, systole.
That's the rhythm of life, essentially.
Right.
Relax and fill, contract and pump. It's incredibly coordinated.
It's amazing it just keeps going.
The efficiency is remarkable. It's not just a simple squeeze. It's a very precise electrical and mechanical sequence.
Okay, so we have the pump. What about the stuff it's pumping?
Blood. It seems simple, but it's actually pretty complex. Oh, absolutely. It's far more than just red liquid. You've got the plasma, which is the liquid base.
Mostly water, yeah.
Mostly water, but carrying all sorts of important things. Proteins, glucose for energy, hormones, even waste, like CO2.
And you mentioned proteins. Albumin is a big one in plasma. It plays a key role in keeping fluid inside the blood vessels.
How does it do that?
It creates something called osmotic pressure. Basically, it helps hold on to the water, preventing it from leaking out too much into the tissues, like a sponge effect almost.
Okay, like maintaining pressure in the pipes. And then floating in this plasma are the cells. Red blood cells are the most famous ones, I guess.
Definitely. They're packed with hemoglobin, which is the molecule that actually grabs onto the oxygen.
And they're weirdly shaped, kind of like discs. And they don't have a nucleus.
That's right. That biconcave shape gives them more surface area for oxygen exchange, and losing the nucleus basically makes more room for hemoglobin. It's a trade-off. They can carry more oxygen but can't repair themselves, hence their lifespan of about 120 days.
Wow. Constant turnover. Millions produced every second.
Then you've got the white blood cells.
Yeah.
The body's defense force.
Yep, the immune cells. And there are several different kinds: neutrophils, lymphocytes, monocytes, eosinophils, basophils, each with a specialized job.
Like different soldiers in an army.
That's a good analogy. Some are first responders, like neutrophils. Others coordinate the attack, like lymphocytes. They're a small percentage of blood volume, maybe 1%, but crucial.
And finally, platelets. Tiny little fragments.
Tiny but mighty. They're absolutely essential for the first step in stopping bleeding, forming that initial plug.
Okay, so pump, fluid, cells. Now the network they travel through. The blood vessels. Arteries, veins, capillaries.
The plumbing, yeah. Arteries carry blood away from the heart. Think A for away. They have thicker, more muscular walls to handle the pressure.
Makes sense.
Then they branch into smaller arterioles and finally into the capillaries. These are microscopic, just wide enough for red blood cells to go single file.
That's where the real action happens. The swapping of oxygen and nutrients for waste.
Exactly. Diffusion happens across those thin capillary walls. Then the capillaries merge into tiny venules, which join up to form the larger veins.
And veins bring the blood back to the heart. They don't need walls as thick as arteries, right? Lower pressure.
Correct. And many veins, especially in the legs, have little one-way valves to help keep blood flowing against gravity back towards the heart.
Clever design. Now let's talk about what happens when there's a break in the system. Hemostasis, stopping bleeding.
A really critical process. It happens in stages. First, the blood vessel itself constricts. That's vascular spasm. Tries to narrow the gap immediately.
Okay, like pinching a hosepipe.
Sort of, yeah. Then the platelets rush in. They stick to the damaged area and clump together, forming a temporary platelet plug.
But that plug isn't super strong on its own.
Right, it's a quick fix. To make it durable, you need the next stage, blood coagulation or clotting. This involves the famous coagulation cascade.
Ah, yes, the cascade. Sounds complicated.
It is a bit complex, but basically it's a chain reaction. A series of proteins in the blood called clotting factors get activated one after another.
Like dominoes falling.
Exactly like dominoes. The end result is the production of an enzyme called thrombin.
And thrombin does what?
Thrombin is key. It converts a soluble protein in the blood, fibrinogen, into insoluble strands called fibrin.
Fibrin. Is that like a net?
Precisely. Fibrin forms a mesh that traps blood cells and reinforces the platelet plug, creating a stable blood clot that seals the injury.
And you mentioned intrinsic and extrinsic pathways. What's that about?
So there are two main ways to kickstart this cascade. The intrinsic pathway gets triggered by factors inside the blood vessel, like contact with damaged collagen.
Okay.
The extrinsic pathway is triggered by something outside the blood vessel, a substance called tissue factor released by damaged cells nearby.
So two different triggers.
Yeah, providing a sort of backup system. But both pathways eventually merge into a common pathway that leads to thrombin and then fibrin formation. It's very tightly regulated, though. You don't want clots forming when they shouldn't.
Right. That seems crucial. Which brings us neatly to when things do go wrong. Like a heart attack, a myocardial infarction.
Yes, that happens when blood flow to a part of the heart muscle itself gets blocked, usually by a clot in a coronary artery. Those heart cells are starved of oxygen and start to die.
Often because of plaque buildup, right? Atherosclerosis.
Very often, yes. A clot forms on top of a ruptured plaque.
And stroke, that's like a brain attack.
In essence, yes, interruption of blood flow to the brain. Two main types we need to think about.
Ischemic and hemorrhagic.
Correct. Ischemic is the most common caused by a blockage, usually a blood clot or plaque. Hemorrhagic is when a blood vessel in the brain bursts and bleeds.
Both damaging brain cells due to lack of oxygen or direct pressure from bleeding. And time is critical for stroke treatment.
Absolutely critical. Time is brain, as they say. The faster blood flow is restored in an ischemic stroke or bleeding controlled in a hemorrhagic one, the better the chance of minimizing long-term disability.
And there are risk factors we can control, like high blood pressure, smoking, diabetes, and some we can't, like age or family history.
Exactly. Knowing the risk factors is key for prevention.
Okay, let's clarify thrombus versus embolus. A thrombus is a clot that stays put.
That's right. It forms in a vessel and stays there, potentially growing and obstructing flow.
And an embolus.
An embolus is a piece of a thrombus or sometimes other material like fat or air that breaks free and travels through the bloodstream.
And it can get stuck somewhere else?
Precisely. It travels until it reaches a vessel too narrow to pass through, causing a blockage downstream. That blockage is called an embolism.
Got it. Now, atrial fibrillation, or AFib, that's an irregular heartbeat.
Yes, often rapid and chaotic, specifically in the atria, the upper heart chambers. Instead of beating rhythmically, they quiver or fibrillate.
And why is that dangerous? Apart from feeling unpleasant, maybe.
The main danger is stroke. Because the atria aren't contracting properly, blood can pool inside them, especially in a little pouch called the atrial appendage. Stagnant blood tends to clot.
Ah, so clots can form in the heart itself.
Yes, and if a piece of that clot breaks off, it becomes an embolus, gets pumped out of the heart, and can easily travel to the brain, causing an ischemic stroke. AFib significantly increases stroke risk.
Do people always know they have AFib?
Not always. Some feel palpitations, shortness of breath, fatigue, but others have no symptoms. It can be detected on an ECG.
And it can be caused by things like high blood pressure or other heart conditions?
Often, yes. Underlying heart disease, valve problems, even thyroid issues or excessive alcohol use can contribute.
Okay, so thromboembolism is the general term for a clot traveling and causing a blockage.
Correct. It covers both venous thromboembolism, VTE, clots starting in veins, and arterial thromboembolism.
Let's talk VTE, deep vein thrombosis, DVT. That's a clot in a deep leg vein usually.
Most commonly, yes, though it can occur elsewhere. Symptoms might be leg pain, swelling, redness, warmth, but sometimes there are no symptoms.
But the big risk is it traveling.
Exactly. The clot or part of it can break off, travel up through the veins, through the heart, and into the lungs.
Leading to a pulmonary embolism, or PE.
Right, a blockage in the pulmonary arteries. This is serious, potentially life-threatening because it prevents blood from getting oxygenated properly.
Symptoms like sudden breathlessness, chest pain, maybe coughing up blood.
Those are classic signs, yes.
Yes.
PE requires urgent medical attention. and DVT and PE together are what we call VTE.
And risk factors for VTE include surgery, immobility, cancer, certain medications.
Yes, anything that slows blood flow in the veins or makes the blood more likely to clot.
What about arteriosclerosis and atherothrombosis?
Arteriosclerosis is the general term for hardening or stiffening of the arteries. Atherosclerosis is the specific type involving plaque buildup. Atherothrombosis is when a thrombus, a blood clot, forms directly on top of one of those atherosclerotic plaques, usually after it ruptures. That's often the trigger for a heart attack or ischemic stroke.
And stent thrombosis. That's a clot inside a stent.
Yes, a clot forming within a coronary stent that was placed to keep an artery open. It's a serious complication, essentially blocking the artery again. Requires prompt treatment.
Finally, acute coronary syndrome, ACS. What does that cover?
ACS is an umbrella term for situations where blood supply to the heart is suddenly reduced. It includes heart attack, myocardial infarction, and also unstable angina chest pain due to severely reduced flow, but before permanent heart muscle damage occurs. It's always a medical emergency.
Okay, that's a lot that can go wrong. Let's talk about treatment, specifically medications aimed at clots. Antiplatelets versus anticoagulants, what's the difference?
It's a key distinction. Antiplatelets, like aspirin or clopidogrel, work mainly by stopping platelets from sticking together and forming that initial plug. They target platelet aggregation.
So they interfere with the very first step.
Pretty much, yeah. Anticoagulants, on the other hand, work on the coagulation cascade itself, those clotting factors we talked about. They interfere with the process of making fibrin, that meshwork.
So they stop the clot from becoming strong and stable.
Exactly. They reduce the blood's ability to form fibrin clots. Examples include older drugs like warfarin, injectables like heparin, and newer ones called DOACs, direct oral anticoagulants, like Apixaban, which is Exhibion.
So different mechanisms targeting different parts of the process, can they be used together?
Sometimes, yes, in high-risk situations, but it significantly increases the risk of bleeding, so it needs careful consideration by the doctor.
Right. Let's dive deeper into Exhibion, or Apixaban, since it featured heavily in the materials. It's a factor XA inhibitor. What does that mean?
Okay, so factor XA, pronounced 10A, is one of those crucial clotting factors in the cascade. It sits right at the point where the intrinsic and extrinsic pathways meet to start the common pathway.
A key junction point.
Absolutely. By specifically inhibiting activated factor XA, Apixaban basically puts the brakes on the whole process further down the line. It reduces the amount of thrombin generated.
And less thrombin means less fibrin formation.
Precisely. So it prevents clots from forming or growing. It works differently from heparin, which needs another molecule called antithrombin III to work. Apixaban acts directly on factor XA.
Does it affect platelets at all?
Not directly on their aggregation, no. But since it reduces thrombin, and thrombin can activate platelets, it has an indirect antiplatelet effect, too.
Okay. And how does the body handle Exhibion? What's its pharmacokinetic profile like? Bioavailability.
Right. Pharmacokinetics is how the body absorbs, distributes, metabolizes, and excretes a drug. Apixaban's bioavailability is about 50%, so roughly half the dose gets into the bloodstream.
And how quickly does it work?
It reaches its peak concentration in the blood about 3 to 4 hours after taking it.
How is it broken down and removed?
It's mainly metabolized in the liver by an enzyme system called CYP3A4, and it's eliminated through both the kidneys, urine, and the bile feces.
Does food affect it?
Interestingly, no. Food doesn't significantly change how much Apixaban is absorbed. Its half-life, the time for the body to eliminate half the drug, is around 9 to 14 hours, which explains why it's usually taken twice a day.
Okay. What are the main reasons doctors prescribe Exhibion? Its indications.
There are several key approved uses. A major one is reducing the risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation. That's AFib not caused by a heart valve problem.
Right, because of that clot risk in AFib we discussed.
Exactly. It's also used for DVT prophylaxis prevention after hip or knee replacement surgery, as these surgeries carry a high risk of clots.
Makes sense.
And it's used to treat existing DVT and PE, and also to prevent them from coming back after initial treatment.
And the dosage varies quite a bit depending on why it's being used, and sometimes patient factors too.
Yes, definitely. For stroke prevention in AFib, the standard dose is 5 milligrams twice daily.
What?
It gets reduced to 2.5 milligrams twice daily in certain patients specifically, those who meet 2 out of 3 criteria: age 80 or older, body weight 60 kilograms or less, or moderate kidney impairment, serum creatinine 1.5 mg/dL or higher.
Why the dose reduction?
Because those factors can mean the drug stays in the body longer or at higher levels, increasing bleeding risk. The lower dose balances efficacy and safety in those individuals.
And for DVT-PE treatment?
For treatment, it starts higher, 10 milligrams twice daily for the first 7 days, then drops to 5 milligrams twice daily for maintenance. For preventing recurrence long-term, it's 2.5 milligrams twice daily. And for post-surgery prevention, it's 2.5 milligrams twice daily.
So it's quite tailored. What about switching between Exhibion and other anticoagulants like warfarin? Is that straightforward?
It requires careful management. Warfarin is monitored with an INR blood test. Apixaban can actually affect the INR reading, making it unreliable for monitoring warfarin during a switch.
Okay, so how do you switch?
Switching from warfarin to Apixaban, you'd typically stop warfarin and start Apixaban once the INR drops below 2.0. Switching from Apixaban to warfarin is trickier. You usually need to overlap them, sometimes using an injectable anticoagulant like heparin temporarily, until the warfarin gets the INR into the target range. It needs close medical supervision.
Got it. Are there people who absolutely shouldn't take Exhibion? Contraindications?
Yes. The main ones are active pathological bleeding, like a bleeding ulcer or brain hemorrhage, and a history of a severe allergic reaction to Apixaban itself.
And what about major warnings or precautions?
A big one is not stopping it abruptly without medical advice unless there's significant bleeding. Stopping suddenly increases the risk of clots, like stroke. If it needs to be stopped, say, for surgery, alternative anticoagulation might be needed temporarily.
Okay.
Another really important warning involves spinal procedures like spinal anesthesia or epidural catheters. Taking Apixaban increases the risk of a spinal or epidural hematoma, which is bleeding around the spinal cord.
That sounds serious.
It is. It can cause paralysis. So the timing of stopping Apixaban before such procedures and restarting it afterwards is absolutely critical and requires careful planning between the medical teams.
You mentioned drug interactions earlier with liver enzymes like CYP3A4 and something called PGP.
Right. CYP3A4 is a major enzyme that metabolizes Apixaban, and P-glycoprotein, PGP, is a transporter protein that pumps drugs out of cells. Some other medications can strongly inhibit or induce both of these.
What happens then?
Strong dual inhibitors drugs that block both CYP3A4 and PGP can cause Apixaban levels to rise significantly, increasing bleeding risk. Doctors might need to reduce the Apixaban dose or avoid the combination.
And inducers.
Strong dual inducers drugs that boost CYP3A4 and PGP activity can lower Apixaban levels, making it potentially less effective at preventing clots. Combining these with Apixaban is generally not recommended.
So patients need to tell their doctor about all medications they're taking, including over-the-counter stuff and supplements?
Absolutely crucial. Also, combining Apixaban with other anticoagulants or even antiplatelet drugs like aspirin or NSAIDs increases bleeding risk, so that needs careful assessment.
What about specific groups? Pregnancy, breastfeeding, kidney or liver problems?
Generally, Apixaban isn't recommended during pregnancy or breastfeeding due to limited data and potential risks. It's also not advised in severe liver impairment. For kidney impairment, as we said, dose adjustments might be needed, especially for the AFib indication. Its use in children hasn't been established yet.
Now, something that seemed really significant was the mention of a reversal agent, andexanet alpha or Andexa.
Yes, that's a major advance. It's an antidote specifically designed to reverse the effects of factor Psi inhibitors like Apixaban and rivaroxaban.
So if someone on Exhibion has life-threatening bleeding,
Doctors now have a specific way to rapidly counteract the anticoagulant effect. It's a critical safety development for managing major bleeding emergencies.
what about overdose? If someone accidentally takes too much?
High doses in trials didn't necessarily cause major problems, but obviously it's not desirable. If an overdose is recent, giving activated charcoal can help.
How does charcoal work?
Activated charcoal binds to the drug in the stomach and intestines, preventing it from being absorbed into the bloodstream. It's a common strategy for managing certain overdoses if given soon enough.
The materials also mentioned the types of doctors interested in Exhibion: cardiologists, neurologists, surgeons, GPs.
Yeah, that reflects its wide range of uses. Cardiologists for AFib, neurologists for stroke prevention, orthopedic surgeons for post-op DVT prevention, GPs managing many of these conditions. It's relevant across many specialties involved in thrombosis.
And finally, there was some insight into the marketing side, focusing on trials like Aristotle and Amplify to show benefits compared to older drugs like warfarin.
Exactly. The Aristotle trial compared Apixaban to warfarin for stroke prevention in AFib, showing benefits like reduced stroke risk, less major bleeding, and lower mortality.
And Amplify.
Amplive IY compared Apixaban directly to the standard treatment of enoxaparin, followed by warfarin for treating DVT and PE. It showed Apixaban was as effective but caused significantly less major bleeding. These trial results are key messages used to position the drug.
So wrapping this all up, it's clear the cardiovascular system is this incredible, complex machine,
Truly remarkable engineering.
but also vulnerable, especially to issues with blood clotting, understanding the basics of flow, clotting in conditions like AFib, DVT, PE. It seems really important for anyone wanting to be informed about their health.
Absolutely. And medications like Exhibion, these factor AZ inhibitors, represent a targeted way to manage those risks, interfering specifically with the coagulation cascade.
And having that reversal agent, Indexa, adds a significant layer of safety management. It shows how treatment is evolving.
Definitely. It provides reassurance for both doctors and patients in those critical situations.
So thinking about this whole interconnected system, the heart, the vessels, the blood itself, what's a key takeaway for listeners? Maybe something practical.
Well, considering all the risk factors we discussed for things like stroke, heart attack, VTE, many of which are lifestyle related, like blood pressure, diet, smoking, activity levels, it really highlights how our daily choices impact this entire system.
That's a great point. So maybe a question for everyone listening to ponder, reflecting on everything we've discussed. What lifestyle adjustments could you make, big or small, that might positively influence your cardiovascular health and maybe reduce some of those risks we talked about today?
It really brings it back to personal agency, doesn't it? How we can actively participate in maintaining the health of this vital system.
Well, this has been a really thorough deep dive. Hopefully it's shed light on the information you shared and made these complex topics a bit more accessible.
I hope so too. There's always more to learn, of course.
Absolutely. So we encourage everyone to keep exploring. What other questions do you have now about heart health, blood disorders, or maybe even specific treatments? Let us know, and perhaps we can tackle them in a future deep dive.